Good morning. Today the lecture will be about the thyroid function test. The objective of this lecture is to state the element of the thyroid function test and how each test can be used in the appropriate situation. Also to differentiate between the euthyroid, hypothyroid and hyperthyroid state. To determine the difference between the primary thyroid defect, secondary and tertiary thyroid defect, and what is the difference between them, and also to define and determine the subclinical thyroid illness and the non-thyroidal illness. The investigation that are done to determine the thyroid function are the TSH, the thyroid stimulating hormone, the free T3 and free T4, the total T3 and total T4, thyroid autoantibody وعندنا أنواع من الثايرويد autoantibody, and rarely we can use the thyroid releasing hormone test. A routine use are the TSH and the thyroid hormone. Sometimes we do investigation and do biochemical, we request biochemical test for certain element and analyze that are not part of the thyroid function test, but they are affected by any disturbance in thyroid function. Example, blood glucose, lipid profile, creatinine kinase. Although all these can be must be checked when we have abnormality in thyroid function. قبل ما نبدي لازم نعرف إنه what is the euthyroid. It means that an individual have no thyroid related disorder, while the hypothyroidism it is under activity أيضا نسميها أو decrease production of the thyroid hormone. Hyperthyroidism طبعا هو الopposite اللي هو overactivity of the thyroid gland وعندنا excessive secretion of the thyroid hormone. الديفكت ممكن يكون بالجلاند نفسها نسميه primary بالثايرويد جلاند primary thyroid defect، أو ممكن تكون بالهاير سنتر اللي هي البيتيوتري that secrete TSH or the hypothalamus that secrete the thyroid releasing hormone. But mainly most commonly the defect is in the thyroid gland بنسميه primary thyroid defect, whether it is hypothyroidism or hyperthyroidism. أول تيست هو الثايرويد stimulating hormone. نعتبره this is the first line thyroid function test. Why? Because it is the most sensitive one. إذا كان patient have a normal hypothalamus, a normal pituitary, and the result of the TSH was normal, then I can exclude hypothyroidism and hyperthyroidism. إذا كان طبيعي الهايبوثالاموس ما عندي مشكلة بيه والبيتيوتري، فإذا طلعت الريزلت مال TSH normal then I can exclude any thyroid abnormality. While if the hypothalamus and pituitary are normal but the result of TSH is abnormal, for example, if the patient have a high TSH in the presence of a normal hypothalamus and pituitary, then this indicates that the patient have hypothyroidism, primary hypothyroidism. And in case the TSH was very low in the presence of a normal hypothalamus and pituitary, then this indicates the patient have primary hyperthyroidism. طبعا أكيد when I have a TSH abnormal, I need to confirm it by measuring the level of thyroid hormone in the blood. The other test is the T4, or it is called Thyroxine. It will complement the TSH assay, and any abnormality that we found in the level of TSH we must confirm it by T4. The T4 أحيانا يكون هو first line in certain condition. إذن هو TSH دائما هو first line، ما عدا بحالات قليلة يكون T4 ممكن راح ياخذ first line as an investigation. هاي الحالتين هي لما يكون patient he have already a well-known case of hypothyroidism, primary hypothyroidism, and he started on treatment. طبعا treatment هو replacement treatment إذا عنده hypothyroidism، يعني معناته إنه ال production of thyroid hormone حيكون قليل عنده، فال level of thyroid hormone in the blood we can monitor it by measuring the level of T4. يعني هو راح ياخذ الثايروكسين as a treatment, as a supplementary alternative or replacement therapy instead of the low thyroid hormone أو low thyroxine that is produced by the thyroid gland. يعني هو patient عنده hypothyroidism، ممكن احنا primary hypothyroidism ونعالجه بالثايروكسين. بهالحالة ال TSH ياخذ وقت يلا يرجع إلى النورمال. ممكن احنا بهالحالة نعتمد على البلاد ثايرويد T4 level، ممكن نعتمد على البلاد T4 level إذا كان البيشنت هو عنده primary hypothyroidism وon treatment، والتريتمنت عادة يكون replacement by thyroxine. sometimes اكو delay between انه يرجع TSH to its normal level وبين انه التايم لاج، فبهالحالة ممكن اني اعتمد على level of T4 واعتبره هذا indicative of the thyroid function. يعني إذا كان low means that ممكن يكون نحتاج إنه we increase the dose or if it is high then we decrease it. نعتمد على الثايرويد level، على T4 level عفوا. الحالة الثانية اللي أقدر أعتمد بها على T4 ويكون البرفورمانس مالته better than the TSH when the patient have secondary and tertiary hypothyroidism. بهالحالة when you have a secondary and tertiary hypothyroidism the defect is not in the thyroid gland itself. The defect either in the pituitary gland, any defect that destroy the the TSH releasing hormone from the pituitary gland or the TRH releasing cell from the hypothalamus. ممكن إنه because of loss of the stimulation I have no The other test that is part of the thyroid function test is the level of the T4 or the level of thyroxine. This test usually will complement the result of TSH assay. يعني we did the TSH and we found that the level is either increase in the level of TSH or decrease. Then we want to confirm our diagnosis, then we confirm by measuring the level of T4. As we know that usually TSH is the first line investigation and it is the most sensitive test among the thyroid function tests, except in two conditions in which the level of T4 is the first line assay. دائما نعتمد على TSH ما عدا in two conditions اللي يكون بيها T4 more reliable than the TSH. These two conditions are if the patient is on treatment for hypothyroidism. Usually in case the patient have a primary hypothyroidism, the treatment will be replacement with thyroxine. One of the problem in this condition is that the hypothalamic pituitary thyroid axis take months to return to its normal dynamic regulatory mechanism. So the TSH will delay until these axis return to its normal, and there be a certain delay in the time. So if we measure TSH in this time, when in the delay time, then the result will be misleading. يحتاج وقت TSH to fully equilibrate and return to the dynamic of the regulatory mechanism of the hypothalamic pituitary thyroid axis. بهالوقت we can measure the performance of the thyroid function by measuring the level of T4. هذا واحدة من الكونديشن اللي نفضل بها measurement of T4 on the TSH and it will be more reliable. الحالة الثانية لما يكون عندي secondary and tertiary hypothyroidism. What I meant by secondary hypothyroidism لما يكون the defect is in the pituitary gland. In case the defect is in the pituitary, or I call it secondary hypothyroidism, there is certain defect in the pituitary gland that mainly in the cell that secrete the TSH that may be destroyed by, for example, a tumor, by fibrosis, by whatever the cause, so that there will be decrease in the production of the TSH, and because of its decreased production there will be a low stimulation of the thyroid gland to produce thyroid hormone. I call it secondary hypothyroidism. بهالحالة it is not very useful to measure the level of TSH, and we can use T4 as an alternative and it will be more reliable. وكذلك إذا كان عندي defect is in the hypothalamus. I have tertiary hypothyroidism. In this condition also we depend on the level of T4. when يكون عندي tertiary defect, meaning that the defect is in the hypothalamus, and in this condition there is destruction of the cell that produce the thyroid releasing hormone that stimulate the TSH to produce the TSH, and then TSH will stimulate the thyroid gland to produce the thyroid hormone. If I have defect at the level of the hypothalamus, what is called the tertiary hypothyroidism, it is preferable to use T4 rather than TSH. So in these two conditions only T4 is better than TSH and more reliable. If a patient is already diagnosed as a case of hypothyroidism and he is on a treatment with thyroxine. The second case, when the patient have secondary or tertiary hypothyroidism. The T3 is another test that also can be used in the diagnosis of thyroid disorder. The free T3 is more sensitive than the T4, and mainly it can be used in two conditions. The first is when the patient have a variety of thyrotoxicosis that is called T3 thyrotoxicosis. In this condition, only the T3 increase, TSH is low, and the T3 increase while the T4 is normal. So if we, in this condition, we depend on T4, the T4 will be normal in this condition, so it is not reliable, while T3 give the right diagnosis. So in this condition, in T3 thyrotoxicosis, T3 is very sensitive and must be used in the diagnosis. Generally, in hyperthyroidism state, T3 is more sensitive than T4 in confirming the level of low TSH. So in case of primary hyperthyroidism, the first line is the TSH. We found that it is low, very low, and we want to confirm it by the thyroid hormone level. We choose to measure the level of T3 because T3 is more sensitive in diagnosis hyperthyroidism. The free T4, sometimes we have certain abnormality that may affect the level of the binding protein. We know that the thyroid hormone are bound in about 99% will be a protein bound, and less than 1% is the free. The protein bound, usually they are bound to thyroxine binding globulin or to the prealbumin and to the albumin with different affinity. Normally, in euthyroid state, about a third of the binding sites on the thyroxine binding globulin are occupied by the T4, and the remainder are unoccupied. While in hyperthyroidism, both plasma total and free T4 are increased, and the number of the unoccupied binding site on the thyroxine binding globulin will be lowered or decreased. In case of hypothyroidism, the opposite of the above. If for any condition the level of thyroxine binding globulin increase, it will cause an increase in both the bound T4 and the unoccupied binding site, but it will not affect the free T4. So in this condition, measuring of the free T4 will be very important. This increase in the level of the thyroxine binding globulin may occur in different conditions. For example, in a female, it depends on the estrogen state. So increase in the estrogen during pregnancy or in the newborn infant, the level of estrogen will be very high, so it's preferable to depend on the free rather than depending on the total T4. Giving estrogen in general as a treatment and the use of oral contraceptive pills also will cause increase in the thyroxine binding globulin. It will increase the total and will give a misleading result. Sometimes even we have certain inherited defect will cause increase in the thyroxine binding globulin. The opposite occur in case of decrease in the thyroxine binding globulin. أحيانا ممكن يقل in case of severe illness أو أحيانا إذا we have loss of the low molecular weight protein. For example, in the urine, in case of nephrotic syndrome, there will be increase in the loss in the urine. راح يقل الثايروكسين binding globulin وبالتالي راح تقل تنفذ false indication of the state of the thyroid function. A treatment مثلا by androgen or any androgen containing medication, أيضا it will decrease the thyroxine binding globulin and affect the result. وكذلك we have inherited deficiency of the thyroxine binding globulin that may decrease its level and will affect the result and give a pseudo decrease in the total level. We must be aware in case of to all of these conditions that we mentioned, because they will cause misinterpretation of the level of the result of the thyroid function test, and they may be misdiagnosed as hyperthyroidism or hypothyroidism if we depend only on the total level of the plasma total T4 level. For this reason, the free T4 concentration we prefer it now. Even we have certain medication, for example the salicylate اللي هو الأسبرين and the danazol, bind to thyroxine binding globulin and it will displace the T4. The change in the unoccupied binding site is variable in this case. أحيانا ممكن even we can measure the plasma thyroxine binding globulin concentration and it can indicate or confirm if the patient have a congenital defect in the level of the congenital thyroxine binding globulin excess or deficiency. Determination of the antithyroid antibody are also requested as a part of the thyroid function test after confirming that the patient have either hyper and hypothyroidism. They are requested. We have many types of these autoantibody. These autoantibody may be directed against the thyroglobulin, the glycoprotein that is found inside the colloid thyroid. In the thyroid follicle we have the colloid, and inside it they have the thyroglobulin, which is the site for the synthesis and later on the release of the thyroid hormone. Sometimes we have autoantibody against this molecule, or we have antibody against the enzyme that catalyzed most of the steps that are important in thyroid hormone synthesis, which is the thyroid peroxidase. So we have antibody sometimes against it, and it causes the defect in thyroid function. Sometimes the antibody are directed on the receptor, which are the site for the attachment of the TSH. So we have the thyroid receptor, thyroid stimulating hormone receptor autoantibody against the receptor. Rarely there is an autoantibody against the thyroid stimulating hormone or against the T3 hormone or the T4. The most common of all of these is the thyroid peroxidase autoantibody. It is common in most of the thyroid autoimmune disease, but it is not very specific because it can be found in other non-thyroid illness. And may be found in other autoimmune disease. In certain malignancy we can find this autoantibody. So the most common is the thyroid peroxidase autoantibody, but it is not specific because it can be found in other condition outside the thyroid in other side other than the thyroid disease. The thyroid receptor antibody, which are the receptor that directed against the receptor, the site for attachment or the bounding of the TSH to the thyroid cell or thyroid gland, they are heterogeneous because they may be stimulating after attachment of this autoantibody to the thyroid gland. They may stimulate the gland, so they will produce more thyroid hormone and they end in thyrotoxicosis. Or sometimes these autoantibody bound to the TSH receptor but with no effect. Or sometimes they have a blocking effect. They bound to the receptor and they decrease the thyroid stimulation and production of thyroid hormone. So it may be either stimulation resulting in thyrotoxicosis, or they bound without effect, or they maybe have a blocking effect and result in hypothyroidism. This picture shows some of the clinical manifestation of a patient who have thyroid disease. This is a goiter, which is enlargement of the thyroid gland, and this is the exophthalmos, the eye sign present in case of thyroid disorder. Now we will discuss the change in the thyroid function test in each case of hypo or hyperthyroidism and according to the level of the defect. Hypothyroidism can be defined as underactivity of the thyroid gland so that there will be failure to maintain adequate amount or level of the thyroid hormone. So there will be generally in every thyroid hypothyroidism, whatever the cause, there will be decrease in the level of the T3 and the level of T4. It's either caused by a structural or a functional defect, so that the thyroid cannot produce adequate amount of thyroid hormone. The defect would be in the anywhere in the hypothalamic, pituitary, and thyroid axis. Hypothalamus secrete the TRH that is important for stimulation of the pituitary to produce the TSH to stimulate the thyroid gland, and the thyroid gland will produce the T3 and T4. So if the defect was in the gland itself, the thyroid gland, then I call it primary defect, or if it is in the pituitary gland, anything that interfere with its ability to produce the TSH, I call it the secondary defect or secondary hypothyroidism. And if the defect is in the hypothalamus, so that it cannot produce enough thyroid releasing hormone, then the defect will be tertiary. So if it is in the thyroid, it is primary, pituitary, secondary, and in the hypothalamus, it's a tertiary hypothyroidism. In primary hypothyroidism, the defect is in the thyroid gland itself. Variety of causes, maybe the first and the most common cause was the defect in iodine deficiency. Iodine is a vital part, essential part in the structure of the thyroid hormone. So in case there is iodine deficiency, there will be a defect in the synthesis of the thyroid hormone. Could be caused by radiation of the thyroid gland, repeated radiation in the area, in the neck area, and this may result in fibrosis and inability of the thyroid cell to produce the thyroid hormone. Sometimes there will be post-operative hypothyroidism when there is a history of hyperthyroidism and surgery was done to remove parts of the thyroid gland, that the active part. Then after a period of time there will be hypothyroidism in the remaining part of the thyroid. Sometimes maybe the primary hypothyroidism may be due to autoimmune thyroiditis, for example, any autoantibody that bound to any of the element, maybe thyroglobulin against the thyroglobulin or antibody against the TSH receptor, that will affect the production of the thyroid hormone. If the defect is in the thyroid gland itself, a primary defect, primary hypothyroidism, and the defect in the gland itself, then the thyroid function tests will show the following profile. The TSH will be high in an attempt to stimulate the thyroid gland, and the blood level of the T3 and T4 will be low, both the total and the free. So in case of primary hypothyroidism, the thyroid function test profile will be high thyroid stimulating hormone level and low level of T3 and T4. In case of secondary and tertiary hypothyroidism, the thyroid gland تكون عادة normal, and the problem lie either in the pituitary gland in case of secondary or in the hypothalamus in case of tertiary defect. The thyroid can function normally, but it doesn't receive stimulation by the thyroid stimulating hormone from the pituitary, or the thyroid releasing hormone from the hypothalamus will be defective or low, and so that the TSH will be low, and finally the thyroid gland will be affected. In case the defect was one in the pituitary gland itself, then the thyroid function test profile will be that the TSH will be low, and the T3 will be low, and the T4 also is low. And in case the defect is in the hypothalamus, in this case the thyroid releasing hormone will be low, and the TSH will be low, and the T4 and T3 all will be low. فنميز ما بين البرايمري and the secondary and the tertiary hypothyroidism by the level of the TSH. بكل الأحوال T3 و T4 will be low. الديفكت إذا كان بالthyroid gland itself راح يكون TSH high. But if the defect is in the pituitary gland, because there will be no production of TSH, for example fibrosis or destruction of the cell that produce TSH by tumor, or surgery, or whatever the cause, the TSH will be low. وكذلك بما أنه we have low TSH, there are no stimulation to the thyroid, and eventually T3 T4 will be low. إذا كان level of the defect أعلى بالhypothalamus بهالحالة راح يكون even the TRH يكون low، وبما أنه pituitary even if it is normal, but because it doesn't receive stimulation from the pituitary by the TRH, then the TSH will be low, and then the T3 T4 all will be low. Hypothyroidism presented as slowing in the physical and mental activity. It is generally a hypometabolic state. It results from decrease in the level of thyroid hormone, so there will be weight gain, fatigue, dry, brittle hair, bradycardia, constipation. The first screening test for primary hypothyroidism is the TSH, and it will be increased in the primary form. We can confirm it by the total T4 and the free T4, and we can measure also the thyroid autoantibody to give a clue about the etiology or the cause of hypothyroidism. Hyperthyroidism is a hypermetabolic state. There will be overactivity of the thyroid gland, and there will be excessive secretion of the both T3 and T4. The primary hypothyroidism, the defect is in the thyroid gland itself, and there may be an toxic adenoma that secretes large amount uncontrolled autonomous secretion of large amount of the thyroid hormone, maybe toxic multinodular goiter, maybe Graves' disease, maybe autoimmune thyroiditis. If the defect was in the thyroid gland itself, we call it primary hyperthyroidism, in which the thyroid hormone will be increased in amount, while the TSH will be low because of the negative feedback inhibition. While if the defect is in the other center outside, for example pituitary or hypothalamus, then there will be increase in the level of the TSH, and the T3 T4 also are high. So in all cases of hyperthyroidism, the T3 T4 will be high, and if the cause was in the pituitary gland, then, or for example some tumor, TSH secreting tumor in the pituitary or outside, then it is secondary hypothyroidism. Otherwise, if the defect was in the thyroid itself, then the TSH will be low. فالميز بيناتهم عن طريق TSH. بكل الأحوال هي الثايرويد هرمون تكون elevated. It's essential for diagnosis, and to determine the site or السبب ال site for increase. إذا كان ال defect in the gland itself, then TSH will be low. وإذا كان ال defect in higher center pituitary hypothalamus راح يكون ال TSH will be high. الكلينيكال فيتشر برزنتيشن راح تكون عكس الهايبوثايروديزم، كلها تدل على الهايبر ميتابوليك ستيز. There will be weight loss despite the appetite, good appetite. There will be a heat intolerance. There will be fine tremor, palpitation, nervousness, fatigue, hair loss, and irregular menstrual cycle and goiter. There is a variety of a condition that is called the euthyroid sick syndrome اللي أيضا نسميه non-thyroidal illness. إنه أحيانا أثناء checking there will be an abnormal level of thyroid hormone with a normal TSH. The defect is either sometimes we have an acute or chronic illness اللي هي not related to the thyroid gland itself, but it can change the result of thyroid function tests. The main thing that can diagnose this condition is that the serum TSH concentration are normal. This is the main milestone in this condition, is that the serum TSH concentration are normal. The early manifestation is decrease in the level of the T3. Later on there is other change in the level of thyroid hormone, but usually TSH concentration is normal. In case we suspect that this patient have the non-thyroidal illness or euthyroid sick syndrome اللي هو a defect is outside of the thyroid gland but results in abnormality in the result of thyroid function test, we defer the investigation. نأجله لحد ما إنه acute or chronic condition of the patient improve, and we then repeat the test because it is difficult to interpret in this condition. The mechanism that caused the euthyroid sick syndrome may be induction of the central hypothyroidism, or there will be certain, due to the acute or chronic illness, there will be a release of cytokine, cortisol, and dopamine that suppress the TSH release, or sometimes may be defect in the level of the thyroxine binding globulin and other thyroid hormone binding protein, change in the concentration of this protein or change in the affinity will lead to change in the level of the thyroid hormone and may cause misinterpretation of the result of thyroid function test. This could occur also in case of pregnancy, which is a physiological condition, or maybe due to drug or acute and chronic illness. So we can define it as the condition in which either the plasma total or thyroid concentration is abnormally changed without clinical evidence of thyroid illness. And the hallmark is that the TSH may be in most cases remain normal. Some other causes of impaired or non-thyroid illness is the uptake of thyroid hormone by the tissue may be impaired, or there will be, we know that the T3 is the active form of the hormone, so if there is decrease in the conversion or deiodination that convert the T4 to T3, then the patient may end in euthyroid sick syndrome. As we said, in this condition, if we suspect that the patient have the euthyroid sick syndrome, then we defer the thyroid function testing until the acute illness is resolved. The subclinical thyroid illness is another state. Also, sometimes we call it compensated thyroid state. What we mean by this condition is that the change is only on the level of the TSH, but the level of the thyroid hormone are normal. It could be hypo or hyperthyroidism. In case of subclinical hyperthyroidism, the patient may be asymptomatic but have a depressed or decrease in the level of the TSH and a normal free T4 and free T3. While in case of subclinical hypothyroidism, the plasma TSH concentration is raised, but the total or the free T4 are still within the reference range. Some patients may be asymptomatic, some have some features suggestive of hypo or hyperthyroidism. It is called compensated, as the pituitary try to compensate for the defect in the level of the thyroid hormone. In this condition, it is opposite to that of euthyroid syndrome. In this condition, the TSH is abnormal, both in case of subclinical hyperthyroidism or hypothyroidism. When the patient is confirmed to have hyperthyroidism or hypothyroidism, some biochemical tests are affected secondary to defect in the level of thyroid hormone. So this test is not part of the thyroid function test, but it must be done to check the general state of the patient. In case of hyperthyroidism, which is a hypermetabolic state, in this case, if we check for the blood glucose level, the patient will show a diabetic response. So there will be increase in the level of the blood glucose. The cholesterol will be low. Sometimes we have change in the level of the liver enzyme, and the level of plasma calcium and the alkaline phosphatase will also increase in case of hyperthyroidism. The opposite may occur in hypothyroidism. The cholesterol is high because of the low metabolic rate, and the creatinine kinase may increase because of myopathy. The prolactin level may increase. There will be hyperprolactinemia and galactorrhea. This may be secondary to the effect of the TSH, and the sodium level will be low. These also are not part of the thyroid function test, but may cause a serious clinical consequences, so must be checked when we suspect that the patient have hyper or hypothyroidism and treated accordingly. This is a scheme for the strategy for thyroid function test interpretation. If we have a high TSH, then so the first line of investigation or screening, we measure the TSH. If the level of the TSH was high and increased, then we check the level of the T4. If the level of T4 is high, then the diagnosis and will be pituitary hyperthyroidism. You must interpret the case as a pituitary hyperthyroidism. There will be overproduction of TSH from the pituitary gland, and this will lead to overproduction of the T4 from the thyroid gland, and the result in must be interpreted as pituitary hyperthyroidism. In the second case, if the TSH was high but the T4 is normal, in this condition it is interpreted as a subclinical hypothyroidism, or what is called compensated hypothyroidism. In this condition, the TSH will try to increase to stimulate the gland to produce more thyroid gland to maintain the level within the normal range. While if the TSH was high but the T4 is low, this is interpreted as primary hypothyroidism. Primary hypothyroidism. In case the TSH was normal but the T4 is high, then this can be interpreted as a non-thyroidal illness or sick euthyroid symptom. Why? Because the TSH is normal. If both the TSH is normal and the T4 is normal, the patient is normal euthyroid. He have no thyroid abnormality. If the normal TSH accompanied by a low T4, in this condition, since the TSH is normal, it is also severe non-thyroidal illness or the sick euthyroid syndrome. So the TSH, in case it's normal and we have any abnormality in the thyroid hormone, it is euthyroid syndrome. If TSH is normal and the T4 is normal, the patient is normal. And this in the last condition, when we have the TSH is low and the T4 is high, this is a classical primary hyperthyroidism. While if the TSH is low and the T4 is normal, then this is a subclinical hyperthyroidism. subclinical, it is a compensated hyperthyroidism, and if the TSH is low and the low T4 is low, then the defect is in a higher center, either pituitary or hypothalamic hypothyroidism, because of the low stimulation of TSH, low production of TSH by the pituitary gland or then the hypothalamus. By releasing TRH, the result will be low production of T4. In this condition, it is either pituitary or hypothalamic hypothyroidism. So the interpretation, mainly the first line, depends on the level of the TSH. هذا السكيم represent الملخص للمحاضرة. It is an easy way to remember the interpretation of each of the thyroid function tests in each different condition. This is a scenario that helps you to learn how to interpret the result of thyroid function test. A 32 years old housewife attended her physician. She lost weight, she was irritable, and had hot intolerance. She was taking estrogen containing oral contraceptive pill. By examination, her palms were sweaty with fine tremors. When we request the thyroid function test, the following result, we have the TSH was less than 0.01, where the normal was less than 0.02, so nearly it is undetectable or very low. While the free T4 is 19, the normal range is 9 to 21, so it is within the normal range. The total T4 is 160, where the normal is up to 150 nanomole per liter, so it's slightly elevated. The free T3 is 12, where the upper normal reference is 6.2 picomole per liter, so it's elevated, and the total T3 is 6.5, where the normal is up to 2.4 nanomole per liter. So what is the diagnosis, or how can you interpret the result of the thyroid function test? We can see that the TSH is very low, the T4 is within normal of the free, the total is slightly elevated, the free T3 is elevated, and the total T3 is also elevated. So we have an undetectable or very low TSH and elevated free T3 and total T3, both are elevated. The T4 are normal. This is a case of T3 thyrotoxicosis. We depend on the diagnosis on the very low level of the TSH and the elevated T3, both free and total, with a normal T4 level. The slightly elevated level of the T4 slightly above the normal. The total is due to that the patient is taking oral contraceptive pills, and they increase the level of the thyroxine binding globulin. I will give you more case scenario, and you can learn how to interpret them as a homework. Thank you, and ready for any question.